السلام عليكم شباب.
عليكم السلام دكتور.
اليوم ناخذ infections of the small and large bowel. كملنا الانفلاماتوري بول ديزيز المحاضرتين السابقات اللي هو السلف كولايتس والكرونز ديزيز، واخذنا اخر سلايد هو المقارنه بين الكرونز والسلف كولايتس ذات تذكرون. اليوم infections of the small and large bowel. The common infections هو الاميبياسيس اللي هو ديزنتري وكذلك تي بي اكتينومايكوسيس وهكذا. Start by intestinal amoebiasis. Amoebiasis is infestation by amoeba histolytic. تتذكروها. This parasite has a worldwide distribution and it's transmitted mainly by fecal-oral route through the contaminated drinking water. The ulcer who have been described as a bottle end because of this considerable undermined edge. Have a yellow necrotic floor from which the blood and pus will be exudate. Through the endoscopic biopsy or fresh hot stool are examined carefully to look for the presence of the parasite itself. Regarding the clinical picture of amoebiasis, intestinal amoebiasis, dysentery is the principal manifestation of the disease as a medical problem, but it may come from the other surgical presentation of amoebiasis, like appendicitis or amoebic cecal mass. Therefore, when we operate on the amoebic dysentery without precaution, prove fatal because advanced amoebiasis. Perforation, the most common site of the perforation is the cecum and rectosigmoid junction. Severe rectal bleeding may be presented with amoebiasis as a result of separation of the slough is liable to occur. Fourth presentation or surgical presentation, granuloma, progressive amoebic invasion of the wall of the rectum or colon with secondary inflammatory process may give granulomatous mass, which is difficult to distinguish it from the malignancy unless by biopsy. Ulcerative colitis. So we search for amoeba in any patient suspected to have ulcerative colitis. Fibrous stricture may follow a healing of extensive amoebic ulcer. Intestinal obstruction is a common complication of amoebiasis. Paracolic abscess or ischiorectal abscess fistula occur from perforation by amoeba of the intestinal wall followed by secondary infection. Treatment of intestinal amoebiasis is a medical treatment by metronidazole, giving 800 milligram for 3 times daily for 7 to 10 days. Diloxanide furoate is a base for chronic infection associated with the passage of the cyst. When the cyst is present, the treatment by diloxanide. Intestinal antibiotic improve the result of chronic stage that is complicated by superadded infection. With the amoebic dysentery, the antibiotic may be needed. Another infection, typhoid and paratyphoid. The typhoid usually presented with the paralytic ileus, the most common complication of the typhoid. Intestinal hemorrhage may be a leading symptom, and other surgical presentation of the typhoid like hemorrhage, perforation, cholecystitis or phlebitis, and genitourinary inflammation, arthritis, and osteomyelitis. Regarding the typhoid ulcer, perforation of the typhoid ulcer usually occur during the 3rd week of infection. The ulcer is parallel to the long axis of the gut and usually situated in the terminal ileum. So when there is perforation of the terminal ileum, should exclude perforated typhoid. When operate on the patient with the emergency peritonitis and we found perforation of the should exclude typhoid. Here in the paratyphoid B infection. What about TB of the intestine? TB can affect any part of the gastrointestinal tract from the mouth to the anus. وهي سمعناها الكلمة بالكرونز disease. The site affected most often are the ileum, proximal colon, and peritoneum. There are two principal types, ulcerative type and fibrotic type. Okay, ulcerative type of the TB usually secondary to the pulmonary TB and arise as a result of the swallowing of the tubercle bacilli of the infected patient. There are multiple ulcers in the terminal ileum, usually lying not longitudinal, lying transversally, and overlying cirrhosis is thickened, reddish, and covered with the tubercle. Regarding the clinical picture of this type of the TB, is diarrhea and weight loss are the predominant symptoms, and the patient usually receiving treatment of pulmonary TB. عادة هو non-case of pulmonary TB. A barium and follow-through of the small bowel enema will show the absence of the filling of the lower ileum due to narrowing, and cecum and most ascending colon as a result of the narrowing. Treatment of the ulcerative TB usually by course of chemotherapy, anti-TB drug. Healing often occur provided the pulmonary TB is adequately treated. Operation is rarely needed and perforation or intestinal obstruction. عادة due to complication by perforation or intestinal obstruction of the TB, the operation need in this rare indication of surgery. Hyperplastic TB is usually occur in the ileocecal region, although solitary and multiple lesions in the lower ileum are sometimes seen. This is caused by ingestion of Mycobacterium tuberculosis by the patient. Okay. Attack of the abdominal pain and intermittent diarrhea, usually the presenting symptom of the hyperplastic TB. The ileum above the partial obstruction is distended, and the stages of subsequent infection leading to the steatorrhea, anemia, and loss of weight. Sometimes the presenting picture is a mass in the right iliac fossa, which is give differential diagnosis of the appendicular mass and the other, like carcinoma of the cecum, Crohn's disease, TB, or actinomycosis of the cecum, in addition to the appendicular mass. Regarding the radiology, barium follow-through or small bowel enema will show a long, narrow filling defect in the terminal ileum. Treatment, complication like obstruction, okay, treatment is by chemotherapy, is advised and may cure the condition where the obstruction is present or complication is present in form of intestinal obstruction. The operative treatment is required and ileocecal resection is indicated of the disease segment of the bowel. Last thing is actinomycosis of the ileocecal region. Abdominal actinomycosis is rare, unlike intestinal TB. Narrowing of the lumen of the intestine does not occur. Mesenteric lymph node does not involve. However, a local abscess separate to the retroperitoneal tissue and adjacent abdominal wall, or even to the skin, becoming a seat of the multiple indurated discharge sinus to the skin. The usual history of the actinomycosis is after appendectomy. After 3 weeks after appendectomy, the site of the surgery become like a mass in the right iliac fossa, and the wound become to discharge. At the first, the discharge is watery, thin, but the later become thick and malodorous. Pus should be sent for bacteriological to exclude actinomycosis and reveal characteristic silver granule in the microscopical examination. The treatment is a medical treatment by penicillin or trimexazole. Treatment should be prolonged in a high dose. What about the small bowel? We compared to the large bowel, the tumor of the small bowel is rare. Start by benign tumor of the small bowel, include adenoma, submucous lipoma, and gastrointestinal stromal tumor. Sometimes reveal themselves by causing complication like interception, and the second most common complication is bleeding from the adenoma, in which the diagnosis is frequently long delayed because the tumor is overlooked at the barium, radiology, endoscopy, and even surgery may be mistake or overlooked. Peutz-Jeghers syndrome, this is autosomal dominant disease, consists of intestinal polyposis, hamartomatous polyposis, affecting the whole small bowel and the colon, where it can cause hemorrhage and often interception. And the other presentation of this syndrome, melanosis of the oral mucosa and the lips. Long-term follow-up of the patient of the Peutz-Jeghers syndrome. The patient may have reduced survival, secondary or due to complication or recurrent bowel cancer, and development a wide range of the cancer, including ovarian cancer, cervical, gastric, or colorectal, that associated with the Peutz-Jeghers syndrome. The polyp can be thickened to trees. The trunk and the branches are smooth muscle fiber, and the foliage is virtually normal mucosa. Treatment as a malignant changes are rare occur. Resection is the only necessary for the serious complication like bleeding or interception. There is no prophylactic resection of this syndrome because the malignant changes is very rare. Large single polyp can removed by enterotomy, or short length of the heavy involved segment can be resected, and end-to-end anastomosis will be done. The incidence of further lesion developing problem like reduced by thorough intraoperative examination at the time of the first laparotomy, or by using on-table enteroscopy and polyp suited for removal can be identified, and usually treated by endoscopy or colonoscopy by snaring, okay, forceps snared. This picture of the Peutz-Jeghers syndrome is very rare in our locality. Show hypermelanosis of the lips and the mucous membrane. Another malignant tumor of the small bowel, the first one is lymphoma, is commoner than carcinoma. There are three types of lymphoma: Western type lymphoma, primary lymphoma that associated with celiac disease, and Mediterranean non-Hodgkin B-cell lymphoma in origin, and they may be present with obstruction and bleeding. Very rare, presented with the perforation and anorexia with weight loss, usually obstruction and bleeding. Primary lymphoma that associated with celiac disease, this is now T-cell lymphoma, presented with the worsening of the patient diarrhea of the celiac disease, with pyrexia of unknown origin and together with the obstructive symptoms. Mediterranean lymphoma, this is found mostly in the North America and Middle East in our locality, is associated with the alpha chain disease. Unless there are particular surgical complications, the condition is a medical, treated by chemotherapy. Regarding the carcinoma of the small bowel, مثل ما قلنا, it is rare in comparison with the large bowel carcinoma. And like small bowel, other tumor, this may be present with obstruction, bleeding, or diarrhea. Complete resection offer the only hope of treatment. Other tumor is carcinoid tumor. These tumors occur throughout the gastrointestinal tract, most commonly in the appendix, ileum, and rectum. The most commonly affected is appendix. They arise from a neuroendocrine cell at the base of the intestinal crypts. Primary is usually small, but when metastasized to the liver, usually, this called carcinoid syndrome rather than tumor. The tumor can be produce a number of vasoactive peptide, commonly 5-hydroxytryptophan, serotonin, which may be present with as 5-hydroxyindole acetic acid in the urine during the attack. Clinical syndrome itself consists of reddish blue cyanosis, flushing, attack, diarrhea, loud sound in the bowel, bobargamy called, asthmatic attack, and usually sometimes pulmonary and tricuspid stenosis. Classically, the flushing attack is induced by alcoholism. The treatment of the carcinoid tumor and syndrome, most patients with gastrointestinal carcinoid do not have carcinoid syndrome. Surgical resection is usually sufficient in case when it is incidentally or accidentally discovered after appendectomy. Nothing is required after appendectomy. يعني إذا اكتشفتها the appendix is involved by carcinoid tumor and the appendectomy done, there is nothing required after appendectomy. In patients with the metastatic disease, multiple inoculations of the hepatic metastasis or even partial hepatectomy can be carried out, and the treatment has been usually the new treatment of the carcinoid syndrome by medical treatment of somatostatin analog that called octreotide to decrease the secretion of this tumor. Gastrointestinal stromal tumor, this is a group of the disease, either benign or malignant. An increased size is associated with the malignant potential. Gestated tumor is a type of sarcoma that develop from the connective tissue cell. It is found most commonly in the stomach, but can found in the other side of the gut, even esophagus, duodenum, okay? It occurs most commonly in the 50 to 70 years old group. The presentation of the gestated tumor, patient may be asymptomatic. Other symptoms include lethargy, pain, nausea, hematemesis or melena, that called upper GIT bleeding. Treatment of this gestated tumor is by surgery. The most effective way to remove gestated tumor, because they are radio and chemo resistant. هسه ناخذ the most common tumor of the bowel, which is large intestinal tumor. Benign tumor, the term polyp is giving any description of any elevated tumor called polyp. Can occur single or synchronously in the small number, or is a part of the polyposis syndrome. Like in familial adenomatous polyposis, FAP, more than 100 adenoma are present. It is important to sure of the histological diagnosis because adenoma have a significant and increased risk of carcinoma. Classification of the polyp, either inflammatory or metaplastic or hamartomatous or neoplastic. Metaplastic like hyperplastic polyp, hamartomatous like juvenile polyp or Buttes-Jigger polyp. Whether neoplastic, which is very important, adenoma, there is 3 types of adenomatous polyp, like tubular or tubulovillous or villous. The villous one is more associated with the malignancy. Adenocarcinoma where carcinoid tumor can be presented with the polyp. Type of polyps, adenomatous polyp vary from the tubular adenoma rather like a raspberry on the stalk to the villous adenoma, which is a flat spreading lesion. A villous tumor more usually gives symptom of diarrhea, mucus diarrhea, or mucus discharge, and occasionally hypokalemia. The risk of malignancy develop in adenoma increase with the increasing size of the tumor or polyp. For example, 1 cm diameter tubular adenoma, there's 10% risk of cancer, while the villous adenoma over 2 cm in diameter, there may be increased risk of carcinoma like 15%. Adenoma larger than 5 mm in diameter usually treated because of their potential malignant potential. Colonoscopic snaring of the polyp or diathermy obliteration with the biopsy forceps can be used. A huge villous adenoma of the rectum can be difficult to remove by endoscopic maneuver, even with the technique per anus, and occasionally need proctectomy or removal of the involved segment of the rectum. Familial adenomatous polyposis, a FAP, is clinically defined by presence of more than 100 colorectal adenoma. Over 80% of cases of the FAP have positive family history. 20% is as a result of new mutation in the adenomatous polyposis coli gene, APC. This has been identified on the short arm of chromosome 5. Although the large bowel is mainly affected, polyps can occur in the stomach, duodenum, and small intestine. So it is not restricted to the large bowel. Can occur in other sites of the bowel like stomach and duodenum or small bowel. The main risk of the large bowel cancer, but the duodenal and the umbilical tumor can be reported. It is inherited as a Mendelian dominant condition like autosomal dominant. The risk of colorectal cancer is 100% in patients with FAP if untreated. Male or female are equally affected by FAP. FAP can be associated with the benign mesodermal tumor, such as desmoid tumor and osteoma, with epidermoid cyst give syndrome called Gardner syndrome. When the FAP associated the desmoid tumor, epidermoid cyst with the osteoma called Gardner syndrome. يعني رباعي حتى تتذكرها. رباعي FAP, epidermoid cyst, desmoid, osteoma called Gardner syndrome. Desmoid tumor in the abdomen invade locally to involve the intestinal mesentery, and although non-metastatic disease, but it's become sometimes unresectable. This خاصة بالدesmoid tumor. Clinical picture of the FAP, polyp are usually visible on sigmoidoscopy by the age of 15 years and will almost always be visible by the age of 30 years. Carcinoma of the large bowel occur 10 to 20 years after the onset of polyposis. Okay, يعني ثلاثينات, okay, أربعينات, usually affected by carcinoma if it is untreated, if it is not operated. When the symptomatic patient, there are either patients in whom a new mutation have no family history, or those affected family but have not screened and not treated, presenting with the symptom, which is include loss of stool, loose stool, lower abdominal pain with weight loss, diarrhea, and passage of the blood and the mucus. Polyps are seen on sigmoidoscopy and double contrast barium enema. If in doubt, colonoscopy is the essential to do biopsy and establish the number of the and histological type of the polyp. If over 100 adenoma are present, the diagnosis is made by colonoscopy. Asymptomatic patient, direct genetic testing will reveal mutation in 90% of cases, with the site of mutation within the gene has been important effect on the phenotype. If there is no adenoma by the age of 30, the FAP is unlikely. If the diagnosis is made during adolescence, the operation is usually deferred to the age of 17, 18 years old, or when the symptom or multiple polyp will be evident. Screening policy of the FAB: at-risk family member are offered genetic testing in their early teens. At-risk member of the family should be examined at the age of 10 to 12 years, repeated every year, examined by colonoscope. Most of those who are going to get polyp will have them at 20 years, and this should be required surgery. If there are no polyp at 20 years, continue to follow up to exclude either it is no FAB, or examine until the age of 50. If there is still no polyp, it is unlikely to be FAB. Treatment: colectomy with ileorectal anastomosis has in the past been the usual operation because it is avoid ileostomy in a young patient. The risk of pelvic dissection to nerve function. So the colectomy with ileorectal anastomosis has in the past have the usual operation to avoid ileostomy and pelvic nerve damage. Alternative is the restorative proctocolectomy, which is with ileoanal anastomosis. This higher complication rate than ileorectal anastomosis. It is indicated in patients with the serious rectal involvement with polyp. If the rectal involvement, there is no rule of colorectal or total colectomy, just without proctocolectomy, with the preserve of the rectum. Because the rectal involvement, the rectum should be excised in form of proctocolectomy with ileoanal anastomosis, but it is associated with a higher rate of complication. Another type of colorectal cancer, but not polyposis, called hereditary non-polyposis colorectal cancer, Lynch syndrome. This syndrome is characterized by increased risk of colorectal cancer and also cancer of the other side of the body, like endometrial, ovary, stomach, small bowel. It is an autosomal dominant condition that caused by a mutation in one of the DNA mismatch repair gene, like MLH1, MS2, MS6, BMS, and BMS2. The lifetime risk of developing colorectal cancer is 80%. The diagnosis of this Lynch syndrome can be diagnosed by genetic testing or Amsterdam criteria 2. When there is the 3 or more family member with the hereditary non-polyposis colorectal cancer related cancer, and one of whom is a first degree relative of the other two successive affecting generation, or one or more of the hereditary non-polyposis colorectal cancer related cancer diagnosed before the age of 50, to be grown before the age of 40. Exclusion of the FAB is one Amsterdam criteria of the Lynch syndrome. Regarding the malignancy of the large bowel، ناخذها الأسبوع الجاي كل حذافيرها بالإيميديولوجي، بالباثولوجي، بالكلينيكال بيكتشر، بالتريتمنت. سي كولون ناخذه الأسبوع الجاي بحيل الله. إذا عندكم أي سؤال سألوا.